Okay, hi, hello, I'm Simone. I am with the Department of Health and the University of Cape Town. I'm in the field of psychology, chronic pain, and in the field of aging adults. I am also currently working with the Samson Institute for Aging Research, which is where this data comes from. I'll be presenting my master's mini dissertation on this cross-sectional analysis. Just a little bit of background on the topic. Globally, adults aged 60 and above are growing at a rapid rate with a phenomenon known as population aging. As you can tell by this image, if you look between 1990 and 2050, there is a 4 times increase in aging adults, which is of concern, which is why I feel that we need to pay a lot of attention to this phenomenon of global aging, as we all know. Just a little bit about my 2 main topics. Pain in general, it is a global emerging public health concern, specifically, particularly among older adults who are prone to experiencing frequent pain, either be it chronic pain due to pain-related conditions or multimorbidities, as well as acute pain, either from falling or from having surgery or cancer pain. According to the South African Demographic Survey, which was conducted in 2016, pain prevalence and pain chronicity was actually only measured for the first time in older adults in South Africa, and the results showed a 33% prevalence of pain. As for poverty, this is quite a complex phenomena. It can be measured in various ways globally in research. You can use monetary measures, non-monetary measures, health measures, and so forth. For this study, I used trade-offs, which is a poverty proxy for poverty. It's a concept that is used quite predominantly in Canada, which is a more first-income country. For an example of making a financial trade-off would be, for example, if you had X amount of limited money and you had to choose between either buying food or purchasing electricity. And evidence has demonstrated that living in poverty-stricken conditions has an association with increased pain, particularly among vulnerable populations such as older adults. This cross-sectional analysis is a sub-study of a longitudinal study called the Wellbeing Study, which is currently being conducted by the Samson Institute for Aging Research. It consists of 3 rounds, the baseline, 6 months, and at 18 months. It makes use of a multidimensional health tool called the Checkup Self-Report, which is an inter-eye assessment tool. The data used for this cross-sectional study was baseline assessments that were conducted in older adults in primary care settings, specifically in 4 lower middle income communities in Cape Town, which are those 4 communities listed there. Therefore, the main aim of my study was to describe what pain and trade-offs looked like in these 4 different communities, and to assess if an association existed between making financial trade-offs as a proxy variable for poverty, and as well as experiencing pain, which was measured by a validated inter-eye pain scale. And this was done via the use of this multidimensional tool in these 4 sites in Cape Town. The variables that I use, the 2 main variables, the exposure variable is a binary variable, I'm making financial trade-offs, a yes-no answer, and the outcome variable is a pain scale, which is derived from the checkup SR assessment. The 2 items are pain frequency and pain intensity, and an algorithm is formed, and it consists of 5 categories ranging from no pain to daily minimal pain to excruciating pain. This, the trade-offs, the descriptives, just generally overall in the whole population, 52% made trade-offs. And you can tell by looking at the 3 different the 2 low income settings, 77% in Bishop Lavis versus Mumray, which is a more low middle income setting, only 28% made trade-offs. Then the pain outcome variable was dichotomized into daily pain versus minimal pain. If you look at this graph over here, you can see that in the total population, 27% experienced daily pain. As far as I'm concerned, that is quite a high percentage for people to be experiencing pain on a daily basis, especially in more disadvantaged communities and among a vulnerable population. You can also tell by looking at Kailicha Clinic in Woodstock that it's up to 53%. According to the results, the study, it was hypothesized that making financial trade-offs as a poverty proxy would result in increases in pain. However, in this cohort, no association was found after conducting logistic regression in the overall adjusted analysis, nor in any of the 4 adjusted sites. In contrast, this association, however, has previously been documented in numerous studies. A major difference between previous studies that have observed this relationship and this current study is in how the exposure and outcome variable was measured. In previous studies, the variables of pain and poverty were measured differently with more in-depth pain tools and poverty criteria consisting of both monetary and non-monetary, whereas trade-offs is just a single monetary component and did not factor in any of the other components. Therefore, these results need to be interpreted within the context of the use of a multi-dimensional tool, which collects very broad and not in-depth, very in-depth data. So this was a major lesson in using a multi-dimensional assessment tool when measuring such complex exposure variables. Therefore, while the results did not actually show an association, this study did highlight very valuable information about what pain and the amount of poverty or trade-offs made, what it looks like in these communities, and we can see where we need to put our resources. Future interventions and policy, it's important that they factor in pain management, especially in your lower middle income communities, as it is clearly a problem in these communities. Multi-dimensional assessment tools are great to use, especially within primary healthcare settings for capturing a large amount of health data, as well as it being great for hypothesis generation, as in this case. And future research in this field of pain and poverty should use more in-depth tools, such as the brief pain inventory assessment tool or the multi-dimensional poverty assessment tool. Thank you very much for your time and for listening to my presentation. I'm over and ready for questions. Thank you.
Thank you, Simone. I have a quick question for you. People are not using the Q&A that much, but I have a long list of questions. So can you tell us if you looked at gender differences? You have about a minute to answer.
As research also does highlight that pain is generally a lot more prominent in females, which the results did indicate, with 66% of the overall population being female versus the remaining 34% being male.
Okay, and the trade-offs that women would make because of pain, are they different from those that trade-offs that men would make? Did you look into that?
No, I didn't. I didn't go into the types of trade-offs made. With it being a binary variable of making a trade-off, yes or no, I did not go into detail on that. But that is a very good suggestion to look into what type of trade-offs are being made. As I said, trade-offs is not commonly used it's not a commonly used monetary measure. It is mainly used in Canada. So finding something that is more appropriate in a lower middle income country like South Africa would be something to look into.
Yeah. Thank you very much. Very interesting.